With me is Dr. Tiny Nair. Son is a senior cardiologist from City of Trivandrum. So welcome to CSI TV studio.
Hello.
So you spoke about target organ damage. So most of these hypertensive patients on long-standing hypertension, sooner or later will have this target organ damage. So what is new in the management of these patients, sir?
The point is when we talk about target organ damage, we often don't understand that it's a very complicated subset. Let's start, for example, we have guidelines for the whites, we have guidelines for the blacks. For example, we say that in the black population, RAS inhibitors don't work well. Now, what about Indians? I say that we are non-white, we are non-black. So, do we have a data? Recently, we have a data that came out of ASCOT, a subset, that actually showed that we rather tend to be similar to the whites rather than blacks. For example, in our population, RAS inhibitors do work well, as do beta blockers. So when we choose a drug, for example, a person comes in without any comorbidity, the drug that we choose could be anything. Can be an ACE inhibitor, can be a calcium antagonist, can be a diuretic, anything. But the point is RAS inhibitors don't really take a back seat here. Let's say a person comes with diabetes or CKD. We have huge database now telling us that unlike what we believed till about a year back, that RAS inhibitors don't really score much over non-RAS inhibitor therapy in the background of diabetes. So the point is, as long as you control blood pressure well, it doesn't really matter for a diabetic whether he is on a RAS inhibitor or not. Let's take, for example, CKD. We know that when we use a RAS inhibitor, ACE or ARB, they do slow down the progression of CKD every stage. Microalbuminuria, macroalbuminuria, doubling of serum creatinine, whatever you talk about.
Right.
But the point here is they don't do anything to cardiovascular mortality or morbidity. So the hard endpoints of survival does not change. And that is really very surprising. Take, for example, left ventricular hypertrophy. As clinicians, we see left ventricular hypertrophy in an EKG so often by the bedside. But we don't realize that the moment we see a simple EKG showing left ventricular hypertrophy, that particular patient has a 3 times higher chance of coronary vascular disease, 6 times higher chance of a stroke, and about 15 times higher chance of a heart failure. So are we utilizing this data to translate into practical medicine? At the moment we see it, for example, left ventricular hypertrophy, we need to choose a combination perhaps of an CCB and a RAS inhibitor. And on top of that, the new data shows that perhaps addition of an MRA, let's say spironolactone or an aldactone, would be good enough not only to reduce the left ventricular hypertrophy, but to reduce cardiac death.
So the most of the benefits are because of that class of group of agents, or there are some specific agents. For example, if we choose a RAS inhibitor, does the data differ from ARBs versus ACE inhibitors? And between the class itself, does the data differ?
So the main theme is we should control blood pressure to the goal. I mean, that is number 1, number 2, and number 3. And as long as we do that with whatever effective medication we do, we achieve our goal, let's say to the tune of 90%. Okay. But then we have drug difference between the class, where we decide to choose what should be the best for my patient. A person who has got a persistent tachycardia would obviously be understood to have higher sympathetic level, and we would use a beta blocker, logical. Okay. A person who has a high level of RAS, for example a CKD or a diabetes, are likely to benefit by a RAS inhibition. I mean, so we should logically choose the drug, but the first point is that the blood pressure should be controlled to goal, and that probably is most important. If you look at the Cochrane data analysis that came recently, let's say ACE versus ARB, all the major cardiovascular event rates are similar. So today we say that whether you choose an ACE or I choose an ARB, they kind of are similar. So you can straight away go for an ARB for hypertension rather than waiting for an ACE, producing a problem, patient comes back, you change to ARB. The problem in this in the Indian population is that I write an ACE inhibitor, the patient gets a cough, he may never come back to medicine. He might start thinking that, oh my God, I didn't have a problem to start with, this doctor wrote something for me and I have a cough. Oh, I will not go back to the doctor at all. And we lose the patient. So I would rather prefer a drug which is as good as a placebo in its side effect, very low side effect problems, and effective, and that tends to bring down the blood pressure to goal as my choice.
So you brought a very important point that if you diagnose LVH in a EKG, this patient is obviously at a very high risk.
Yeah.
So does the physician's approach in management need to be differ or need to be customized because of this?
It should, it certainly should, and that is the take-home message. The moment you see an EKG showing in left ventricular hypertrophy, that patient carries a very high risk, fine. But the point is EKG good enough to diagnose LVH? No. EKG might pick up the left ventricular hypertrophy in about 25% of cases. But if you do an echo, for example, in a large majority you would find left ventricular hypertrophy, which might be missed out by the EKG, and that's the problem with EKG. So whether EKG LVH or echo LVH, the point is an LVH gives an impression that this patient has a very high risk of cardiovascular event, and I'm going to treat them aggressively, perhaps with more than one drug, and perhaps a combination of CCB and a RAS inhibitor.
True, so that's very important. I think we need to customize or we need to individualize our management approach based on these findings.
Exactly.
And a very important point, if we have missed an LVH on EKG, so how do you suspect that still there could be LVH and this patient need to be investigated further?
We basically say that on clinical medicine, for example, if you see an elevated jugular venous pressure, JVP, in a patient who has left ventricular hypertrophy, think of LVH, because it's the septum, thickened septum, that is giving rise to elevated JVP. So clinically you can suspect, EKG can suspect, and we say that today echo being so common, cheap, available everywhere, perhaps you should do a screening echo for every long-standing hypertensive to look whether at the point whether they have got a left ventricular hypertrophy or not, because that would make your treatment different.
And early identification will probably help us in controlling the target organ damage as well.
Exactly, exactly.
So thank you, sir. Thanks a lot for joining and sharing your views with us.
Thanks.
Thank you, sir.
The point is when we talk about target organ damage, we often don't understand that it's a very complicated subset. Let's start, for example,